UCI. We have our hub team here with us today, and Dr. Tam will be presenting today's session. Thank you again for being here. Next slide.
Oops. Sorry, I just lost the screen there.
No. So we're going to be following the following agenda: introductions and announcements, again with our didactic, and we will be having some case discussions throughout as well. And then we'll follow on with the closing and reminders. Next slide, please. As you all know, you guys have been added and are muted upon entry. If you do have any questions along the way, you can put that in the chat or unmute yourself and ask. And we will definitely have time for questions. Next slide, please. We are CME accredited. This session is accredited for 1 CME credit. Usually you get your CME certificates within 3 weeks of a session. Make sure that you do fill out the CME form and that we will share with you at the end of the session. I'll also put it in the chat for you all. Thank you so much. Next slide. We are funded by the Health Resources and Services Administration, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. Next, please. If you can quickly go ahead and put your name, your role, your site and location. Looks like we have about 50 people on the line, so we always love to see where you guys are joining us from. Please go ahead and put that in the chat. It also helps us mark your attendance for the day for the CME certificates as well. And I'll go ahead and introduce our hub team on the next slide. My name is Nika Seville, and I am the project manager for our geriatric workforce enhancement program, and I'm located in Orange, California. And I'll go ahead and have Dr. Segal introduce herself.
Hi, everybody. I'm Sonia Segal. I'm a clinical professor in the Department of Medicine and work within the Division of Geriatric Medicine and Gerontology here at UCI. I'm really looking forward to today's talk, and I welcome you all to our session today.
Thank you, Dr. Segal and Dr. Pereira.
Hi, everybody. I'm Manisha Pereira, one of the geriatricians here at the Senior Health Center in Orange. Welcome.
Thank you. And PA Valerie George.
Hey everyone, my name is Valerie George. I am a physician assistant. I work at the Senior Health Center in Orange in geriatrics. Welcome to our session today.
Thank you so much, Val, for being here. Okay, next slide.
Again.
Yes, and this is us. We can go to the next slide, and I'll go ahead and have Dr. Tam take it away. Thank you again, Dr. Tam, for presenting today's didactic for us.
Thanks, Nika. So sorry, everybody. Actually, I part of it reason why we're running a little bit behind was I had to discharge a patient on there. But so I'll go ahead and get started. Today, we will be discussing neuropsychological testing. It was framed as the when and the why, but I think it's really just understanding, when we should request for more formal neuropsychological testing and when we do like the basic screening tests or the screening tests or the cognitive testing, what we can do at the bedside in the office, when that is enough and when we need more. I think that those are the questions that we try to take a look around and wrap our heads around. So we'll go over a case presentation. We'll go over briefly the different levels and the echelons of the different cognitive testing and the neuropsychological testing that's available out there. And then when and why essentially appropriate to refer for more formal neuropsychological testing. Okay. So case presentation number one is a gentleman who is 78, who has some medical history just for high cholesterol, some acid reflux, who came in with complaints of short-term memory loss for the last few months. There was a little bit of discrepancy with the wife who felt that it was longer than that, but the patient denied it and feels like it was much more recent. So, the first kind of impression that I got was there was a little bit of just friction between the two in terms of what the actual symptoms were or the degree and, how long it's been going on. But he reports that his basic activities of daily living were fine. He denied any problems where his instrumental activities, daily living, but wife did notice that it was taking him longer to do those activities, including paying the bills and the finances, doing the medications. Driving was okay at the time. and that, there wasn't any frank mistakes reported either by the patient or the wife, but the wife just felt like he was struggling a little bit more in terms of making sure everything was done appropriately on there. He didn't have any problems with his mood that he reported. His wife notes that he's a little bit more easily irritable and short-tempered, though, and that his sleep was generally okay. Medical history is mentioned, just cholesterol, acid reflux, no prior stroke or dementia diagnosed. In the medications, he had Lipitor and pantoprazole on board. There was an old prescription for some meloxicam. He had his own electrical company. At the time of this visit, he still kind of was running it and doing some things related to it. And there frankly wasn't any kind of major problems with his cognitive function disrupting his ability to do his work, but he wasn't doing as much as he used to, and with everything. So no alcohol, no smoking, at least since college on there. He had a college level education. Family history was known for some gastric cancer. Physical exam didn't have any pertinent findings really. He didn't have any deficits on neurological exam. Recent lab workup with another physician was basically normal. Didn't have any neuroimaging done. So with that being done at that time, the symptoms that they're reporting, we decided just to do a screen with him with a mini mental status exam, and it did show missing 2 on the recall portion, with missing some points on different sections of that screening tool. So the question becomes, okay, what do we do next with here, and how much further testing, or what other further testing can we do, right? And we'll jump back to this case towards the end and kind of talk about what we did with him. That's in contrast to another case, case number 2, who, think about the context of that first patient versus the context of this patient here, who's an 84-year-old female who has high blood pressure, who's had coronary disease, who's had a prior stroke with some weakness and deficits there. Lives with the family. The daughter came in with the patient, needs some help with the IADLs in general, with like driving, transportation, getting the shopping done. In the past, it's probably more been because of the stroke than it has been because of the cognitive issues, but has been having progressive memory decline and confusion is what they report, not doing certain tasks with ADLs and doing them wrong, such as toileting in the wrong place in the house, stuff like that was going on. Again, not driving at this point for several years now since a prior stroke. Her sleep and mood was okay. Again, medical history was for vascular type issues, coronary disease, stroke, high blood pressure, medications, your antihypertensives and anti-platelet agents were on board. She was a retired nurse who didn't smoke or drink alcohol. Family history was positive for our father with a stroke. Exam had the left-sided weakness. Labs are essentially normal as the patient's been followed. And she had an MRI not too long ago showing the old prior stroke present. Workup and just screening on her, in contrast, her MMSE was actually 12 out of 30, much more significant, missed all the recall portions. And you get the sense kind of like, well, okay, maybe the history that they presented doesn't really, it kind of fits with this, that level of a deficit present, but whether or not there were some things that they were missing as well in terms of the impact that she was having on there because of the cognitive problems. Okay. Other findings just on mental exam, this is one of those situations where the patient was just very repetitive, kept asking the same question over and over, or kept repeating the same statements over and over. So, with this and the last one, patient, you can think about, okay, there's 2 different presentations there, 2 different levels of impairment based on the history that you're given that you get a sense of, right? And so you're kind of like, okay, when we get this kind of presentations, we're often asking, what do we do next? What kind of further testing or evaluation do we do next at this point? And again, we'll come back to them at the end after we go over some of the talk about neuropsychological testing or the different screening tools. And then we'll kind of go over what we did in these particular cases here, okay? So 2 kind of key points to keep in mind as it relates to doing the cognitive tests, whether it's screening or formal neuropsychological testing. Two things to kind of keep in mind. One thing is that we are talking about how we're using these tests, whether or not we're talking about screening for dementia or not, or when they're presenting with actual symptoms that we're worried about and trying to work it out, right? So for one important part of that, or the important part of that in terms of the screening question, as it stands now, I was just in a meeting this morning and we were kind of talking about screening and kind of mandatory and doing it for everybody across the board versus not. Current kind of practice guidelines actually don't support kind of routine screening for all individuals, especially in those that don't have any symptoms. Okay, so USPSTF, AAN, Canadian Task Force on Preventative Health, none of them really support routine screening. They don't say against it either, but they just don't, have a point of view in terms of, hey, we must do that at this point. So that's something to keep in mind. It's different from the two cases that are presented in the fact that those two are presenting with the symptoms. So, screening again is, when somebody's coming in for their annual wellness visit or other kind of annual exams, and we're talking about screening from that perspective. So I just, we want to put that out there because, in the news recently with lecanemab, is that anti-amyloid antibody, and other agents, we might have more and more patients coming in with these kind of questions about screening and further workup down the road. So the landscape of this might change in the next few years as a result of, some of the technological progression of everything. So that's one important point to keep in mind, that there's a difference between screening and kind of symptomatic workup and evaluation on there. Okay. The other important point that we want to keep in mind as far as neuropsychological testing and cognitive testing goes, is that in kind of the formal diagnostic criteria for making a diagnosis of dementia or major neurocognitive disorder, as it's labeled in DSM-5, it's not that you have to have a specific screening tool done or specific neuropsychological testing and assessment done to make the diagnosis, okay, of dementia or major neurocognitive disorder. Those findings from a screening tool, a cognitive test, a formal neuropsychological test. Important thing to keep in mind about that, those findings from those testing and evaluations, they're evidence for, they're kind of supporting evidence for a cognitive change and decline from prior levels. You can use it from that fact or from that evaluation on there. All right. So that's an important thing in mind, that the testing alone doesn't make a diagnosis of MCI or dementia / major neurocognitive disorder in an individual. It has to be reconciled with the history that's given, all the other information and the context of that patient. Okay. So that's an important thing I want to just point out here. The other components of making a diagnosis is that the deficits for dementia that they do interfere with everyday activities, that they're the root cause of it, that it's not another cause, like in our second case, where the individual had some history of stroke, wasn't driving anymore, and probably wasn't more likely to be driving because of her history of stroke and weakness from that perspective, okay? And then also that it's not occurring in the context of other conditions like a delirium, medical condition, or mental disorder on there. Okay, so that's important things to keep in mind here. So then we come into, okay, so now we have a patient, like our case presentations, where an individual is presenting with symptoms, right? So when they are presenting with symptoms, usually that does prompt some form of evaluation that's done, okay? And again, the degree of testing, that's kind of what we're talking about here, is really guided by, okay, what you think can be done, what you think you can do, and then what's kind of needed in that context on there, okay? So workup, generally speaking, from any kind of memory cognitive complaint, the history is probably one of the largest and the most important pieces of the information that you gather, because it gives you an idea in the context of the situation, how long this has been going on for, what the extent of the symptoms are, what kind of change in the baseline has this patient had in terms of their symptoms. Okay, so that history is one of the most important pieces of information to get on there. Your physical exam, your neurological exam, your psychiatric assessments on there, they're also important pieces of information to get for anything that might help confirm and corroborate what you're thinking in terms of a diagnosis, a potential diagnosis, and also to rule out other contributing sources and etiologies. Okay. Then we get into, okay, what cognitive assessments and neuropsychological tests are being done or should be done, along with what neuroimaging should be done, and evaluation and laboratory testing. The thing about neuroimaging is interesting. It's still a little bit more controversial about, kind of like the screening question about doing it or not in everybody. If somebody actually has an acute change and a rapid decline with a deficit or really significant change in condition, then it is strongly recommended to do some neuroimaging in that kind of situation, because then you're worried about like stroke, bleeds, masses or something like that, depending on what you're concerned about. But in those kind of situations, yeah, you would do an evaluation with neuroimaging. Where it comes into play is a little bit more controversial is when things have been much more chronic and kind of slowly progressing. There's different agencies, different groups that don't advocate for routine imaging. American Academy for Neurology does recommend structural imaging. And again, I think it depends, at least in the initial evaluation, I think it depends on the context of the situation. What other presenting symptoms a patient might have, what the patient and what their family might be hoping for or expecting, or what they're looking for as well. That might influence the decision to make neuroimaging done or not on there. Okay, the whole point of all this too is that during the history, the exam, the imaging, the laboratory testing, is that we're really carefully looking for any kind of medical or other psychological psychiatric etiologies that might be a contributing component of these problems. Okay, so that's the important thing to keep in mind. So some important things about the history taking. I won't dwell on this too much, but getting information about other medical, psychiatric, social histories, drug histories, history of trauma as it relates to memory, those are important on there. Getting some collateral information from a care partner, a spouse, a child, a friend, contact that knows the patient well is important to help give you an understanding of what the course of the symptoms might be, whether it's how long it's been going on for, any symptoms the patient might not be self-reporting, along with the nature, if it's gradually progressing, if it's a sudden change, or if it's kind of up and down from that. They can also give you information about how they're doing with their everyday activities, how they're performing with their finances, community activities, along with household tasks. So that's an important thing to keep in mind when we are taking a history for the patient. Okay. So the cognitive testing piece, and we're using these different terms here, cognitive testing and neuropsychological testing. I'm going to refer neuropsychological testing and just kind of reserve that terminology for the formal neuropsychological testing when you're requesting it. And so that's a little bit different from that perspective, that it's being done with one of our neuropsychologists in that sense. In essence, when we do any kind of mental status exam, cognitive testing, we are getting bits and pieces of the neurological and psychological components to it. So just to help make it a little bit clearer, just keep that in mind, that when we say refer to neuropsychological testing, we're talking about the longer testing for this purpose on here. So, why do cognitive testing? Again, it alone does not make that diagnosis of a dementia or MCI from that perspective, but it helps give us objective findings and evidence of a deficit, if it's there or not. It can help quantify the type of the deficit and the severity of the impairment that's there. Okay, so those are important features to keep in mind of why do it at the bedside, why ask for more testing. Okay, some of the patterns of deficits that might arise in some of the longer tools, the lengthier tools and batteries, the deficits that come up with neuropsychological testing, they'll allow us to get some information and hypothesis. Again, it won't make the diagnosis alone, but it will help support certain hypotheses in terms of, what potential diagnosis this is. I think in one of the other echo sessions, you get information about what a Alzheimer's disease pattern of deficit looks like, what a frontal temporal dementia might look like, what a vascular might look like, what a Lewy body dementia or cognitive disorder might look like. They're going to have different presentations, different areas of cognitive function where they're impacted more than the other, right? So short-term memory for Alzheimer's is the hallmark. Lewy body disease, you get less of the short-term memory components of it and more of the other areas like visual spatial disturbances and whatnot. So you're going to pick up on those on potentially some of these longer instruments and tools from a mental status, cognitive status exam standpoint, along with the neuropsychological. So that's why they are helpful tools in doing all this, okay? These tools, whether it's doing an MMSE for a cognitive screen, a shorter period, or the more formal neuropsychological batteries and testing, they do allow us to follow some of this data over time, and it gives us information how a patient might be progressing or not. Again, some of the arguments about screening kind of apply to this. Why do any of this, right, if we don't have useful treatment options? But they might help us in terms of how to treat a patient's symptoms, and especially with some of these newer potential treatments that are coming down the road here, in terms of getting this cognitive testing done. So it might be a point to like, hey, we should get it evaluated further. We should delineate the type of dementia a little bit further, because, let's say if it's like lecanemab, for instance, it's more applicable. It's going to be applied to those individuals that have Alzheimer's disease as the cause, not somebody that has Lewy body or somebody that has frontal temporal as the cause on there. So again, there might be more utility to all this cognitive testing, whether it's screening along with formal testing in the future as a result of this. And so once again, I just want to make the statement that this testing, these testings do not make the formal diagnosis by itself on here. Okay. In general, there's a lot of different testing and test options that are out there. A good way to think about it is just that there's probably 3 levels to think about. And we'll go over what some of these look like in a moment here. But your screening tools are generally on the shorter side. They're more standardized tools. There's some lack of validation in terms of like how do they apply for all the different scenarios, and like again trying to make more supportive evidence of a formal diagnosis on there. But and we're continuing in terms of the neuropsychological arena where they're continuing to try to validate these tools for different conditions as well on here. So the general screening tools, anything from a mini cog, a memory impairment screen, the 6-item screen are different options, the mini mental status exam, the MoCA, the St. Louis memory screen. Those are all different tools that are out there. These are generally shorter instruments. They give you an idea of different memory and cognitive domains. They're designed to the main point of these are designed to efficiently distinguish a patient that might have an impairment or they might not have an impairment. Okay, that's probably the biggest thing to take away from some of these. Though, in certain conditions, like my patient that has an MMSE of 12 out of 30, I might not be able to have them do more longer testing than that. They might not be able to sit through or get through all of that. So there's probably a lot of utility in doing an MMSE or a MoCA in somebody who's that impaired as it is, just to give you an idea of what level of impairment that they're at. Okay, I think it's just a matter of that context of that situation on there. In general, these tools, they're probably more geared at a memory or kind of short spots that they can really get a quick look at, and they give you a little bit less insight into, all the different areas of the brain that might be affected. So that's something to keep in mind when you're doing the shorter tools. The longer tools, the extended, so that's one level of cognitive testing that exists out there in terms of screening tools. A secondary level is extended mental status and cognitive examination. This is kind of like, when you refer for neuropsychological testing, most folks most of the neuropsychologists will do either a 4 to 6 hour exam. That's kind of like the full shebang, the full catalog, or they might do anywhere from one to 4 hour test, kind of on a shorter side, where they have a smaller battery to give you a different running idea of what might be going on. And so these might involve anything that might include the MMSE or a MOCA to it, or it might have a longer tool like the CASI, the CIRAD, the ACE. These are other instruments that are out there. Some of them have costs associated with it. They're generally, again, combined with other tools. They take longer than 15 minutes to make up that 1 to 4 hour session on there. Okay, these are in general more detailed assessments looking at specific they give you much more information in different areas of the brain. The memory tests are longer than your 3 and 5 item recall on there. They might involve looking at the vocabulary areas. They'll probably involve different problem solving, executive function. They'll test out more with the visual spatial as well, where they'll be much more detailed in that component of it. So each of these assessments can be longer, 30 minutes to even potentially at several hours on there. So you're looking probably about a 1 to 4 hours when you're talking about this on here. And a lot of it will depend on what a patient's able to sit through, what the purpose of that referral will be when you're looking at these longer tools on here, okay? So this second layer falls into that neuropsychological referral realm, because I think we can agree that most primary care areas and even the neurology areas, you know, they just, in terms of their ability and their capability to do these longer assessments when it goes from 30 to 60 minutes, is, you know, a lot of times it's just lacking. We don't have that ability to do that in there, and also the training and experience to do these on here. I've done a few of these in the past, just on the research side, and they do take a long time in terms of doing these here. Okay, and then we get into that third layer where it's that more formal neuropsychological testing. And usually, again, they probably average 4 to 6 hours in terms of a longer visit. These can be split into multiple visits, something to keep in mind. And then we'll go over also some of the reasons of why we would potentially use these, you know, as opposed to the other 2 layers on here. But it can be longer. These are going to involve a battery of tests. In general, it'll include a lot of the components that's in that extended layer, but they might be adding more if they need to look at, if a neuropsychologist needs to look at specific areas of the brain on there. So that's something to keep in mind. A lot of times what I do is when I'm making a referral as such, on the referral, I kind of let the neuropsychologist know that, hey, I'm detecting, you know, a deficit here on the MOCA or the mini mental status exam. Something's kind of out of line. We would like a more formal evaluation done. It can be in that 1 to 4 hour range if I'm just trying to find evidence to support my diagnosis, or in the case of where more formal neuropsychological testing comes into play, is that, you know, this patient has a real unusual presentation, or they might, you know, have other kind of legal proceedings, or I need another opinion in terms of this, you know, evaluate them for that second level, but they might need more assessment to get me in that might involve that third level on there in terms of if you can kind of help decide between that. So sometimes we'll use, or I'll talk to the neuropsychologist to kind of help guide which one of these levels to use on here. But in general, you know, a lot can be done at that second level and doesn't require the full 4 to 6 hours. And then also have to be said, you know, patients have to understand that they could be doing a very long testing on there. They might not want to do the full 4 to 6 hours if they can get some information at that 1 to 2 hour mark on there. Okay, it's not, so that's something to keep in mind in terms of how to approach this. These are just a couple of screenshots of what some of the shorter tools look like out there. The memory impairment screen is a tool that Alzheimer's Association puts out. It's free to use. It's basically a 4-item kind of recall type test where you show them 4 words. You have the patient look at those words. You give them some clues to help delineate which of those words belong to what. And then you, once they've identified what those clues are, that they've given you a sense that they've repeated the words, you take away the list of the words, and then you distract them, and then you ask them back, okay, what were those 4 words? Give them a clue if you have to. So that's, you know, you can do that under 5 minutes. That's a quick screen to kind of give you an idea if there's an impairment or not. The one on the right side is a 6-item screen. It's basically a 3-word recall. You pick 3 words, you have the patient repeat it at the beginning. You could have up to 3 attempts to do that. And then you distract them with some other questions about orientation. And then you go back to those 3 words. So a lot of memory screening just kind of falls around this. Likewise with the mini cog, that's another shorter tool. It's generally, again, a 3-item recall. You have them do the clock drawing test that gives you an idea of what their visual spatial function is like. But it also acts as a distractor on there. It's quick. You know, you kind of stick to the same words that are present. You have different clocks that people draw out there. And I've said it before, I've had somebody give me even a digital clock on here in some instances. You know, they've tried to generate different algorithms related to this. And really, like I said before, that these kind of tests alone aren't going to give me, you know, a diagnosis of dementia or cognitive disorder or not on there, but it really gives us more idea of that there's an impairment or not. And so if you know, one of these short tools comes back with like a positive screen, I might move on at this visit or at a follow-up visit and do a little bit longer screening tool. Again, it kind of depends on the context of how I might approach this in terms of the history on there, right? So I might get them done with a little bit longer to better understand what level of deficits they might have. I might also be evaluating, okay, how anxious is this individual? You know, how much other stressors might be playing a role with everything in terms of like, okay, giving them a break, bringing them back on a following appointment, and then performing a little bit longer test with them during that visit. So that might be in the shape of a mini mental status exam, a MOCA, or even a slums on there. Okay. But what these, the 5 to 15-minute range tests, they give you a little bit more sense of where it's not just the recall portion, but they involve language, a little bit more attention, a little bit more visual spatial. The MOCA in particular, it gives you a breakdown of you know, a little bit more complex tasks, language tasks that are involved in it, along with the naming. So you know, that it's fairly strong in that standpoint. Again, if this is pretty good from the sense that a patient is pretty impaired and in the kind of right history, that might be enough evidence to support a diagnosis for a dementia in many cases. Whereas comes to play if it's picking up, you know, it's like a 24 out of 30 that they're scoring on the mini mental, the MOCA, or the slums on here, where if it's kind of like a mild impairment, you know, that might be picking up a little bit less. You know, they're not as impaired as that individual that has an MMSE of 12. That might require a better understanding of what this person's deficits might be. Those are the kind of instances where we might, if we have the resources available to us, refer for more formal neuropsychological testing. Okay. GP-COG, I actually have this in the wrong place. This is a tool that's on the shorter side that actually, you know, might have some, this is part of our Dementia Care Aware initiative, but we've been advocating for this a little bit more. And this one also has the recall portion, but it's in a little bit different fashion in the sense that you use a little bit longer of a, you know, instead of 3 items, you're doing a 5-item with an address on there. And the name and address of somebody to remember. And I think the other piece of it, it actually details a little bit more about kind of recall of recent events, which I think gives you an idea of another way to gauge memory rather than this immediate recall task on there. Okay, so this is more recent memory. If a patient has been following up, or they should be following up with what's going on in the news, the world, they can give you some of this information. For instance, I'll do things like you know, what holiday was it recently? How was the weather recently? A lot of patients, at least if they're getting out, and again, some of the information, the history that you're given from the patient and the family will help guide you on what question to ask here. Okay, so that's something to keep in mind. So, you know, the thing about these shorter tests and these screens, you know, is how we interpret these results, right? Again, in the context of the history is where it's important. A normal performance on these, it can be reassuring, but we should reconcile it with the history gathered. And we also kind of have to take it in the context, okay, what if this individual is at a very high level of education, high IQ, then we would want to take a normal with a little bit of caution, and it might point us to, well, it doesn't really fit that history if that's correct, right? They're scoring 29 out of 30 or 30 out of 30 on an MMSE, but patient is endorsing some symptoms, wife is endorsing a significant change. There's really a discrepancy there, right? With that, in that kind of scenario, I might be more inclined to order neuropsychological testing in that sense there. Okay, so that's just an important thing to keep in mind. And in general, if there's an impaired performance that might be in that 20 range, that 20 to 25 range, where there's some deficits that are there, it's not completely off the charts, very, very down. And based on the history, they're reporting, some decline. That's where it might push me to order some more formal neuropsychological testing, or that shorter extended testing in that 1 to 4 hour window, because that's giving me additional information on where their strengths and weaknesses might be, helping us to figure out what pattern of deficits this might be in that kind of case, because I can tell at that point there is a pattern of deficit that's showing up already right here. Okay, so in general, we have to consider other causes of these scores, obviously, right? If they've got any medical or psychological, again, that's based on our history and other workup on there. So that's where it's important to have that other information. The other important, where some of these screens and shorter tests might be helpful, is to help kind of gauge how a patient might be doing as they are in the process of, with their disease or their symptoms. Let's say somebody that does have a diagnosis of Alzheimer's, and you put them on Aricept or Namenda, you might be able to track with an MMSE or a MoCA, how their trajectory is going. Okay, now you can also do formal neuropsychological testing to follow them over time, and that might be more sensitive information in terms of the specific areas and detecting that decline on there. So that's the other thing to keep in mind with this. Here are some examples of what there's not, like, so when we order that neuropsychological testing referral, and whether it's in that 1 to 4 hour window or that 4 to 6 hour window in terms of formal testing, there's not like a formal tool that that the neuropsychologists that our colleagues have. They're usually using some battery of different tests, smaller tests that are being done to look at specific areas of the brain function. Okay, that battery can include doing an MMSE. It can include some of these other smaller tests like fluency, naming tests, word lists. Word lists for memory can go out from the 3 to 5 items that we're seeing in an MMSE, the MoCA, out to all the way to 15 words in terms of where they're trying to get up to. And we're looking, and usually with these neuropsychological tests, we're not looking at absolutes. They're usually using standardized measures to compare and see how an individual who is 75 years old that has a college education background, how they're going to fall where they should be scoring. Not that they should get all 15, but do they get 9 to 10 like the average population of that age group on there. So those are things to keep in mind. So again, this is what a battery might look like, having some trail making tests done. The one on the right is an example of the California Verbal Learning Test, an earlier edition of it, where there's up to 16 words that we're having patients repeat over and over, and then we're seeing how many they get afterwards. Here's a couple of other examples of the different tools that are used in the battery here. This is what a Boston naming test might look like, where pictures are shown to patients and they're just frankly naming what they are. So you're testing some of their vocabulary, their visual spatial recognition along with this here. Okay, and these tools kind of have all different evolutions to them. Boston naming test, for example, has anywhere from earlier on it was like a 60 picture test, and it's kind of evolved into like a 12, and there's a 15 picture versions of these on there. Okay, the one on the right here is a trail making test. You see a small portion of this on the MoCA, where you're basically connecting the numbers and letters in alternating and increasing fashion on there. And so you get an idea of their ability to problem solve, and then also their visual spatial abilities to find the right number and the right letter to be able to work through it. You're tested on the amount of time it takes you to do this, and then the errors that you make as well. Again, these are standardized tools from the sense that they're compared to other folks of similar age and see how many mistakes that they're making, how long it takes them to make in terms of how a neuropsychologist breaks this down and analyzes it. Okay. The picture that I screen grabbed here actually had come from an iPad app. So some things to keep in mind with our neuropsychology colleagues, you know, we see kind of like this trend towards computer testing. So some of them might be using these tools on iPads. There might even be self-administered computerized tools at shorter versions. I haven't seen a frank 4 to 6 hour version of this in terms of like just being solely computerized, but I have seen like some 30-minute testing periods, testing programs that are done out there. So just to give you a flavor of, okay, what is actually done with a full neuropsychological test. So again, we talked a little bit about the why do this on here, and it really boils down into the when as well. But you know, important points about those 3 levels of testing is really just as a general rule, it's guided by what the symptoms and complaints and what our assessments are during the time. We can usually start with that screening, the shorter screening tool, and then we make our decisions whether or not we do a more formal neuropsychological request based on what we're trying to deal with, right? A lot of times that comes into play based on these kind of scenarios here. One, if the assessment at the screen are kind of at odds with the history, I can't reconcile it, they don't fit, and that I need to work up that impairment more, then those might be reasons that I need more formal testing. If there are like really significant barriers in terms of language, the level of education, that might be a reason to have our neuropsychology colleagues involved too, because they can get around with translators. They have the level of education standardized into some of the batteries of testing on there, so they can give us more information on there. They can also guide the patient and give them information about, hey, you're really strong in these areas, you're weak in these areas. So when we ask patients and we tell them to stay active, and we try to build up their memory or certain functions as much as we can, you know, we can say, hey, you're really weak in your problem solving abilities. Do more and more of like these kind of tools that kind of help you practice get a little bit stronger in. So that gives us some information from that sense here too. Or where they might need protection. You know, if I know somebody that can't identify things really well on visual spatial, or they're having a lot of problem solving abilities, it might speak to more of like the type of tool that they use for medication management and whatnot. So there's other kind of things to keep in mind here. There might be some other needs of why we would need a neuropsychologist involved. Sometimes capacity. Hi, everyone. Nika, did I get kicked off or am I still?
I can hear you, Dr. Tam, but I can't see your slides.
Oh, let me go back to that. How long did that happen? Did it just happen right now, or?
Yep, just for a few seconds.
I'm sorry about that. Something happened with the computer where it kind of disconnected me, it looked like. Okay, so I'm just about to wrap up and hopefully we can get some questions, and I'm sorry about it took longer than I expected actually. Going back to our first case, the 78-year-old gentleman, just briefly about him. You know, he had that mini mental that was about 24. He missed a couple on the recall. I actually referred him for neuropsychological testing at the time. This was about 3-4 years ago. And he had that California verbal learning test where it was at the 9 items, 9 words. He only got up to 5 of them. We basically helped reconcile that with the history. His ADLs were okay. So we actually diagnosed him with MCI at the time. It's been up to about 4 years, 3-4 years now. His MMSE has dropped down to 18. So it's kind of helped as a tool, and we've been able to use these different tools to follow him over time. I had him do another neuropsychological testing, and he's only getting 1 of those words at this point here. And so that's where some of the value right here on the lower right, just give you an idea of the battery that was done for him in terms of the tools that were assessed. This was on the kind of like the 1 to 2 hour time frame. The other presentation was the 84-year-old who had a much more significant decline in her MMSE. A lot of this was just talking to the patient and the family and going over their health and the decisions to be made about further testing or not. For them, putting her through 1 to 2 hours, I mean, clearly wasn't going to make much difference in terms of her. Well, one thing was she didn't really want to sit through 2 hours of testing, quite frankly, rather than, not even to speak of the 4 to 6 hours on there. So I was just really upfront with them. I told them that like she had a pretty significant vascular history in terms of the diagnosis. She had objective findings of a deficit, even based on the MMSE alone in terms of evidence. And that kind of matches up with the history that was taken on there. So, it was enough for us to talk through it and just say that, hey, this looks like a vascular dementia, vascular impairment that's there. And then we just continue to address what her needs were at that point after seeing this. Okay, so that's kind of the approach that we took between those two. That comes to a conclusion for me here. I am sorry. It looks like because I got cut off, a lot of the questions aren't showing up for me. I'm happy to answer any questions that might be in the chat on there. Dr. Segal or Nika, you guys might see some of the previous questions. I don't know, but feel free to ask in general.
Yeah, we have one question. Jen Crowell says, what are your thoughts on the RUDAS, RUDAS versus the MoCA?
I'm not familiar as much with the RUDAS as the MoCA. I don't know if Jen, you don't mind explaining which one that is. There's a lot of different tools that are out there. If it's what I'm thinking of, it's kind of like along that same time frame in terms of period on there. It might be a little bit longer than 15 minutes.
Hi, Dr. Tam. So yeah, the RUDAS is the Roland Universal Dementia Assessment Scale, and it's just a multicultural cognitive assessment scale.
Yeah.
It covers memory, visual spatial orientation, praxis, visual constructual drawing, judgment, memory recall, and language.
Yeah, I know which one it is. I think from the perspective of they're all fine, really. The Mini-Mental, the MoCA, the St. Louis. I think what they do is that they each give you a little bit, they might have some strengths in certain areas over others, a little bit more information than others on there. For instance, like the praxis part of it. What I would just advocate is that, picking one in terms of your practice that fits, that you can use kind of routinely. Like I try not to jump between I probably tend to use the MoCA much more than any other one, just because of, it's familiar with me. But slums is another one that we have. We've built into our system 3 or 4 different ones just so to accommodate what our providers might want from that. I think that's just the short of it in terms of like the differences between the two on there. But
Okay, thank you for that.
There's one more question. It's pretty long. Eric says, for seniors with caretakers who do not have a need to practice recalling things like today's date, birthday, address, phone numbers, etc., everyday things they can simply not remember for lack of use. Also about clock draws, patients may be used to reading digital. Are there any plans in enhancing the screening tests? Are there cultural, ethical, relevant versions of tests?
Yeah, so there's a lot of, some of the tests that we have, there's a lot of translations that are done out there. And again, Minicog might be one of the more simpler and translated ones out there. I know, like, even Mini-Mental and whatnot, they've been translated. I think that's a great question. Our analog clocks probably will be gone at some point. I don't even know if my kids know how to read them anymore, to be honest with you. But I think the tools are continuing to be evolved with the different practices. I will say that. I don't know that anything's been published kind of more formally. I know that, they're implementing or testing and bringing these out in terms of like, digital, having that discussion there. What I would say is this: if you can't do your usual tool, don't be afraid to use things to find evidence of in terms of helping you, make your diagnosis or support it, right? A lot of times when I have, again, I might have patients that aren't, they have really low education or they can't, follow some of these tests on there. I might have them, and just like, again, that the recent events are an important thing. Like what was the recent holiday, your recent birthday, recent marriage, recent things like that. In terms of that information, I might have them draw other things that the family might corroborate that should be familiar to them. We might look at magazines to point out things to name rather than stuff that they aren't familiar with, and it might be in their native language too. So we've kind of done that just to find objective evidence. It doesn't necessarily have to be in the form of a standardized tool. So I would point that out. But to the original question about, are there plans to enhance the screening tools? I think they're constantly trying to translate these tools, trying to add on, because like I said, even some of the more formal tools like the Boston naming, you've cut down from 60 pictures down all the way to 12 to 15. And they've put different pictures in that are culturally relevant in those kind of cases. So that's probably the best I can answer that question at this point.
Doesn't look like we
Nika?
have any other questions in the chat. Are there any questions on the line? Oh, Mary Ellen Ross wrote, are there screening tools for patients who are blind and cannot draw a clock?
Yeah, I mean, I think those kind of tools go into, so when they're blind and they can't draw a clock, right? You have a visual spatial impairment. You could still test the other areas, right? In terms of verbal learning. There's a mocha line that somebody just pointed out, but essentially a lot of the tools will cut out some of the visual spatial components to it. And the neuropsychologists, even when they're doing formal testing, if they're aware that there's visual spatial disturbances, they'll pick more of the verbal task on there, which is what some of the tools have been modified towards in terms of getting information on. But in your office, then I'd say that you score whatever based on that, and you just really point out the items that are missing, if that's the case, if you don't have easy access to the mocha blind or other equivalents on there.
Thank you so much, Dr. Tam. I know we're out of time. We really appreciate your time today, Dr. Tam, and our hub team as well. Thank you all for your questions. As you all can see, this slide does have the CME form, which was also sent via the chat, and also our session evaluation. If you can scan the QR code, we'll also be sending these slides coming up soon. And then we do have some upcoming sessions. As Dr. Tam did mention, we are going to be covering a lot of the specific dementias out there. So on the 28th, we're going to be focusing on dementia in detail, focusing on Alzheimer's disease. And then on August 2nd, we'll be focusing on vascular dementia as well. So we hope that you guys can all attend those sessions. And again, thank you so much for joining today. Have a wonderful rest of your day. Thank you so much.
Thank you, Dr. Tam.
Thank you.
Thanks, everyone.